So now we are going to look at another one particular condition, okay, which is fairly very easy to understand. Okay, the radiographic features are quite simple. Okay, we are going to look at a disease that is called as Gouty arthritis. Okay, have you ever heard of this term that is called as gout? Okay, gout, right? Okay, gout arthritis. Okay, gouty arthritis is an inflammatory condition which is actually incited by the deposition of the calcium urate crystals inside the joint. Okay, right? And it can happen at any age. And generally, it is actually happening because of a condition that is related down to purine metabolism. Okay, a clinical condition that is related down to purine metabolism. Okay, and it is characteristically a disease which is actually taking down for a long latent periods. Okay, it actually takes something around like 5 to 7 years of development. Okay, and for the deposition of these calcium urate crystals inside the joints actually takes a long time to develop. So it is actually happening because of purine metabolism, right? So uh, if you are good with your biochemistry, actually you have to understand that there are so many conditions that actually which actually cause this kind of problem related down to purine metabolism. Well, for example, to say the similar clinical features that are related down actually happens that if the dietary purines are restricted, or if the diet has got low purine content, or there are some kind of a drugs that there is an abuse of NSAIDs and some of the drugs like colchicine and steroids, well, and endogenous purine productions, or if there are any kind of the drugs that are actually saying that the xanthine uh, actually there is a reduced renal clearance. Okay, reduced renal clearance of the uric acid is actually the ones that are actually causing the the condition called as gout. So whenever there is a reduction in the dietary protein purines or the endogenous purines, or there is a reduced renal clearance, so this one we are actually trying to understand that it is going to cause a condition called as gout. Okay, and it is related down to a particular metabolism which is actually called, no, you see here, it is actually meant, uh, it is usually a clinical diagnosis. Okay, the gout is technically not a radiological finding. Okay, gout is a radiological finding of some kind of a disease that is related down to clinical condition of purine metabolism. Okay, it is a condition that is related down to, okay, it is a condition that is related down to purine metabolism. Let me let me explain what exactly I'm talking about. Okay, you know, while we are actually trying to form the purines in your, which is necessary for your formation of DNA and RNA, right? Where the ribose 5 phosphate is actually converted down finally as down into the uric acid, okay, along the purine metabolism in the cycle. What actually happens is that the ribose 5 phosphate is directly converted down into allantoin, where in between that there is a substrate which is called as the xanthine oxidase, which forms the product of xanthine, which it converts down into uric acid. So xanthine is converted down into uric acid by a presence of enzyme substrate called as xanthine oxidase, where this uric acid produced here under the presence of uricase is going to get down into allantoin, right? Okay, so right now this uric acid has to be excreted, but if it is not being cleared out, it is going to get settled down into the joints, and such kind of condition is actually called as gout. Did you understand? Xanthine the product that is formed down in the purine metabolism from the ribose phosphate is actually converted down into uric acid by a presence of enzyme called as xanthine oxidase. Right? Right? So in such kind of a situation, actually, if there is a problem that is related down to, okay, if that is a problem that is related down to the excretion of this uric acid that is formed down here, is actually called as gout. So generally, whatever you are trying to find out on the radiographs are a characteristic feature of the purine metabolism that is related, but it is not related down to the condition of the bones. Did you understand? That is what exactly I meant by saying it is not, it is clinical, but it is not radiological. Okay, right? So increased amounts of uric acid crystals inside the bones, and technically we are, well, you see here purine metabolism. How? Why are you asking particularly if it is related down to thyroid or not? So what makes you think of that one? Well, yes, you see here, actually, the situation people used to think that, in case of hyperthyroidism, that there used to be the thyroid drugs, okay, that thyroid treatment are the ones that are actually going to cause hypercalciuria, right? Hypercalcemia or hypercalciuria. So, uricemia, you can actually call it as hyperuricemia, right? Thyroid drugs actually may cause a hyperuricemia, and they were thinking before that yes, uric acid may be actually forming from that one, and that is the relation between the gout and thyroid. Okay, well, generally, here, uh yes, there may be, it was an actually, and it was found out that there is an association, okay, in hyperthyroidism there may be increase in the levels of the uric acid, okay, and because of the deficiency of the thyroid hormone, it might actually cause hyperuricemia, and which will eventually cause to leading down to the gout. But generally, you have to understand gout is a clinical condition which is actually happening because of a deficiency in the hormone, sorry, deficiency in the that substrate called as a xanthine oxidase, right? Okay, overproduction of the xanthine oxidase, or if there is an increased purine metabolism, so there will be increased production of the uric acid, and the less excretion of the uric acid is the one that is actually causing gout. But a concomitant increase in the hyperuricemia blood levels, uric acid levels in the blood, may not technically eventually cause gout. Okay, it may be, yes, in high prevalence of gout is present down in hypothyroid patients. That is observed, but it has to be completely investigated. All right, is this fine? It is concomitant increase in thyroid patients, which is related to gout, is there, but technically, yeah, there is still need to see if hyperuricemia is technically causing, presence of gout or not, because gout is classified down as a purine metabolism disorder rather than saying only collection of uric acid crystals, right? Or the same way, since you asked such kind of a question, you see here intake of calcium does not actually cause you calcium stones. Yes or no? High intake of calcium does not actually cause you calcium stones, kidney stones, particularly, I'm talking about. Where if there is a problem in the metabolism of calcium, yes, there will be formation of kidney stones. If not everybody who is drinking milk has to have, you know, kidney stones. Yes or no? No, not everybody is having kidney stones. Only a people, certain people who are going to affect the renal excretion of calcium are the ones who is going to have kidney stones. right? The same way, yes, hyperuricemia is seen in hypothyroidism patients or who are on hypothyroid drugs, and that patients will have hyperuricemia. And hyperuricemia is increased levels of uric acid levels in the blood, right? So it can be happening because of any other condition, but which is particularly happening, and it is the deposition going to happen down in the bones, which is happening because of an enzyme called as xanthine oxidase. It is actually called as gout. Well, association between thyroid and gout is there, but the only association is that there is a high prevalence of gout in case of hypothyroidism, but it is not happening actually thyroid is not the one that is causing the gout. If not, everybody who is suffering from thyroid actually has to have gout. Well, since you asked such kind of a question, I think in pharmacology you should have actually learned about this drug. Remember, there is a drug that is actually called as probenicid. Okay, remember, don't ever forget this line. Okay, probenicid, probenicid precipitates gout. So can somebody tell me what is probenicid? Right, yeah, probenicid is a drug that is used to increase the uric acid excretion, right? And let us say, let us say if there is a patient which is actually wanted the uric acid excretion to be increases, so in such patients where if gout is not present, or technically speaking gout is not yet clinically present, and but however those people actually precipitate, and it will actually try to cause gout in those patients and completely remove of that one. So generally what happens is that these people actually probenicid is generally also try to use gout. But can you tell me what is the drug of choice for gout? Drug of choice for gout? Probenicid precipitates gout. That is true. Probenicid is also used in the treatment of gout. But what is the drug of choice for gout? Allopurinol. Yes, allopurinol is a xanthine oxidase inhibitor, right? Exa- Of course, it is an anti-inflammatory drug itself, but actually, particularly, it is working dependent upon a pathway which is actually inhibiting the xanthine oxidase enzyme. So, it is an allopurinol is the drug of choice for gout. Well, probenicid is also used. NSAID is also used. NSAID is actually only reduce the pain and inflammation, but it is not going to reduce anything that is going to related with uric acid formation. Yes, NSAIDs do not have any kind of a relation to do with uric acid crystal formation. Uric acid crystal formation, if it has to be reduced, xanthine oxidase has to be reduced. So allopurinol is actually going to do it. Probenicid is also going to cause that one, right? So yes, yes, yes. Colchicine, no, colchicine and other drugs. Yes, there are so many other drugs, but allopurinol is the drug of choice. Colchicine is a symptomatic. Yes, benzobromone, bromurone. Yes, all of them. Yes, they can be used. But the drug of choice is allopurinol, and actually allopurinol is a gold compound. Actually, why it is specifically you have to mention, because it is made from gold. Okay? So gold is also actually used in the treatment of gout. Okay, right. However, let's get into the characteristic features so that we can complete the chapter fast. Right. Okay. Gout is generally monoarticular. Okay. Gout is monoarticular always and asymmetric. later in course. And you see here, monoarticular means to say only one or single joint is involved. Okay, and it is more common in males and often affects the metatarsal phalangeal joint of the great toe at the timing of the symptom of onset. Right? Remember, characteristic feature of gout, it is going to affect the metatarsophalangeal joint of the first toe, right? So where the production of there will be an extra grown both formation like thing. Okay, but actually you have to understand that it is not extra grown growth formation, but it is the accumulation of the uric acid along this particular region. Well, it is technically happening more commonly along the metatarsophalangeal joint because uric acid crystals are more tend to end down because of the renal secretion, because of the gravitation. They are going to settle down in the end arterioles. Did you understand why it has to particularly happen down only in the metatarsophalangeal joints? Because of the gravitational effect and because of the mass effect, right? So they are going to finally get down and present down at the metatarsophalangeal joint of the great toe, right? That is the most important characteristic features of gout. And yes, it is a form of erosive arthritis. Yes, hallmark of gout is sharply marginated. Remember, sharply marginated juxta-articular erosion. Okay, outside the articular surfaces, okay, juxta-articular erosion, and they have sharp margins, and they need to have a sclerotic border. Uric acid is a hyperdense material, so they will have sclerotic borders. So the appearance will be generally the overhanging of the edges of the gouty erosions, which are actually called as rat bites. Okay, this is actually called as a rat bites. The erosions that are happening along the great toe is called as the rat bites. Okay, so that is the finding of gout. Giant spice narrowing generally will be a late finding. Okay, and characteristically there will be no osteoporosis. Okay, so collection of the ureate crystals along the soft tissues will be happening. You see here, it is not happening inside the joint. It is actually, sorry, it is happening inside the joint, but it is not happening along anything that has to do with the bone, right? Any kind of a collection of the ureate crystals in the soft tissue is technically considered down as a tophi formation. Okay, so tophus formation, okay, tophus formation along with the sharply marginated juxta-articular erosion seems to be a radiographic feature of gout. Is you understand, right? Is this easy? Gout is fairly clearly a very simple diagnosis. Okay, it actually does not indicate, this radiographic abnormality does not indicate that the problem is present down in the bones. Actually, the problem is present down within the xanthine oxidase and the renal excretion that is related down to the, okay, renal excretion that is related down to the purine metabolism. Okay, so that's the reason why we say it is a clinical disease but not as a radiological disease. And then sometimes olecranon bursitis may also be common, right? And you see here, there is an erosive arthritis. Okay, there is an erosive arthritis, and there is a sharp margination. There is a sharp margination of along the metacarpointerphalangeal joint of the great toe, metatarsophalangeal joint of the great toe. So this one is actually suggesting you that it is going to be gout. All right. So that's the important first characteristic feature what we are looking at, right? And actually these are the juxta-articular rather than being intra-articular. You see here, this one is the articular surface, but you see here there is no any kind of effect that is present down here, but the is present down here, extra growth formation. Now you can be actually asking, what about if it is differentiating? What about, don't you think that it is can be rheumatoid arthritis, osteophyte formation? No, you have to understand rheumatoid arthritis will have joint space narrowing. Gouty arthritis will not have joint space narrowing. Rheumatoid arthritis generally happens in the bigger joints. And gouty arthritis is just only happening principally along the great toe, and it is monoarticular. Rheumatoid arthritis is biarticular. Gouty arthritis is monoarticular. Did you understand now? How can you actually differentiate them all together? Yes or no? We will see the differences together in a single page so that we can actually try to get no more confusion. And you see here, in erosive arthritis, yes, it can be happening. You can actually see that there will be osteoporosis, but here there will be no osteoporosis. So, which is, we can fairly say this is not a fairly a joint disease, but it is technically a clinical disease, which is actually happening because of urine metabolism errors. Okay, and you can see here there is an increased density. There is an increased density along the posterior aspect of the elbow, where there is showing up a hyperdensity along the cubital joint. So this one is the region for the olecranon process, and then there will be an olecranon bursa that is present here. So olecranon bursitis is also a characteristic feature. Okay, olecranon bursitis is also a characteristic feature of gouty arthritis. Okay, so, and you can also see that there is a mild cystic densities that are present down here, which is suggesting down the erosions of the olecranon process, right? Okay, erosions of the olecranon process. So that one, by this we can actually say that it is a form of erosive arthritis. So in such kind of a situation, you see here, when there is only formation of this tophi, which actually indicates that the uric acid crystals have been forming. When the erosions have started, you call such kind of condition as gouty arthritis. If only tophi or the uric acid crystals are formed, you call that condition as gout. Is this point clear? If there is the involvement of joint, generally there will be no involvement of the joint. Generally there will be no involvement of the periarticular surfaces. Generally there will be no involvement of the articular cortex, right? So if only tophi are formed, if the only there is an accumulation of uric acid crystals along the metacarpal interphalangeal joints that is present down, okay, so it is actually called as gout. But if the joint is involved, we call it as gouty arthritis. Yes, yes, that is what true it is. You see here, since we are going to look at the subchondral cysts that are formed, which is actually suggesting that there is an erosive arthritis here. So you can technically say that olecranon bursitis can be a characteristic feature that is helping down to us to identify the rat bite sign of gout. Yes, true. You can say it that way, right? And now here is a very, very particularly interesting disease. I think I have told you last time also to learn about this one. Okay. Well, this condition is actually a very, very important condition, which is actually called as the ankylosing spondylitis. Remember, ankylosing spondylitis is a chronic and progressive form of arthritis, which is actually characterized by inflammation and eventual fusion of the sacroiliac joints. Okay, remember, ankylosing spondylitis is a chronic and progressive arthritis that is characterized by the inflammation and fusion of the particularly sacroiliac joints. Sometimes spinal facet joints are also involved, or the paravertebral soft tissues. Okay, right? Yes, right. So you see here, there is there is this is a chronic inflammation, and then there will be eventual fusion of the sacroiliac joint as well as the spinal flexor joints, which also causes the you know inflammation of the paravertebral soft tissues. So ankylosing spondylitis is a clinical condition, is a radiological condition where there will be fusion of all the sacroiliac joints. Simple. Remember it that way. But it can be happening. Okay, you see here, it is more common in young males. Okay, it is more common in young males and characteristically actually ascends the spine and starting in the SI joints. Well, it starts within the sacroiliac joints, but later and later in life actually goes down to the spine, then moving down to the lumbar, thoracic, and finally cervical spine, which in particular has to have a relation down to a HLA-B27 gene. Okay, remember, ankylosing spondylitis is actually associated with the human leukocyte antigen B27, which is also called as HLA B27, right? I think I also told you about this kind of a clinical condition somewhere. When I was talking about some disease, actually, I talked to you about this HLA B27. If you can remember, can you tell me which disease am I talking about? No, no, it is not related down to musculoskeletal system. No, no, no. Do you remember when I was talking about the celiac sprue, celiac disease? I told you that celiac sprue is a condition which has got the HLA DQ2 and DQ8 problem, right? Which is also going to form joint problems as well as deposition of okay, as well as anemia, right? Celiac sprue, HLA-DQ2 and HLA-DQ8. At that point of time, I was telling that there is a condition that is called as hepatitis dermatiformis. Okay, hepatitis dermatiformis, HLA-DQ2 and DQ8. At that point of time, I was actually mentioning about this HLA-B27, which is actually causing the ankylosing spondylitis. Okay, so remember, do not confuse. Try to find out all the diseases that is caused by the HLA, human leukocyte antigen. Okay, try to find out HLA, okay, human leukocyte antigen. Try to find out all the diseases that are caused by human leukocyte antigen. And particularly here, HLA-DQ2 and DQ8 is actually the one that is causing the celiac sprue, whereas HLA-B27 is the one that is actually causing uh, the ankylosing spondylitis. All right. Okay. Now you have to understand that there will be, abnormal joint connections. Okay, there will be abnormal joint connections where which is actually called as enthesopathy. Okay, remember joining of the all the joints is actually called as the enthesopathy, where there will be inflammation of the joints with subsequent calcification. Well, you see here, rheumatoid arthritis is actually not technically associated with HLA-B27. Where did you hear this one? Okay. See, it is not HLA-B27. I mean to say, yeah, I think maybe you are confused. It is actually caused by HLA-DR4. I was thinking you are trying to say about HLA-B27. No, actually, yes, it is caused by HLA, but actually it is HLA-DR4. One of the reasons, if rheumatoid arthritis is actually caused by related down to genetics, yes, it is caused by HLA-DR4. But if it is not exactly, you see here, it can also be happening because of some other conditions, right? Rheumatoid arthritis is actually happening because of rheumatic factors, right? It is actually happening because of the cytokines, interleukins, okay, interleukin 6 and TNF alpha that is actually being activated. So if it is actually happening as a genetic predisposition, okay, then yes, they are going to, it is actually going to HLA DR4 will be there, right? All right, right. Now, okay. Now, what actually we see here, ankylosing spondylitis is a very, very technically a very interesting disease, which actually happens if it is happening along the spine. It will produce a particular appearance, which is actually called as, I think I told you before. Anybody remember? I think I told you before when I was talking about tuberculosis in lungs. Okay, I was talking about this condition. I remember there I talked about the, okay, I will try to repeat it in the musculoskeletal system. Okay, and ankylosing spondylitis. Ankylosing spondylitis will actually cause you an appearance of bamboo spine. Okay, remember? Can everybody hear me? Can everybody hear me? Okay. So remember, ankylosing spondylitis actually causes bamboo spine. Okay, that's it. That is what you are going to remember. Okay, hallmark of ankylosing spondylitis is actually the sacroiliitis, since it is going to start with the inflammation of the sacrum and the iliac joints. So sacroiliitis is the hallmark feature of ankylosing spondylitis. Well, it is bilaterally symmetrical, okay, leads to bony fusion, okay, leads to the bony fusion or the ankylosis of these joints. Okay, abnormal joints are actually, abnormal fusion between the joints is actually called as ankylosis. Okay, and actually they appear as a thin white line and all, they disappear altogether. So the joints lines that are present between the sacrum and the ilium may actually eventually disappear together. So that's the reason you actually call it as sacroiliitis, and where they will be fused together. And if it is going to happen along the facets of i- if it is going to happen along the facets of the spine, it is going to call it is going to cause a typical appearance, which is actually the syndesmophytes, okay, which is actually forming of the bony bridges between the corners of the vertebrae, okay, which is actually going to form the bony bridges of the vertebrae, which is going to cause you a appearance, a typical appearance of the spine, which is actually called as the bamboo spine appearance. Do not ever forget, this is a very important point. Bamboo spine formation is a typical appearance of the ankylosing spondylitis, okay, which is actually forming the annulus fibrosis, or the bony bridges that are actually formed along the corners of the vertebrae is actually called as syndesmophytes, which actually produces a bamboo spine appearance. Let's see what it exactly it is. You see here, the sacroiliac joint, which has to be present down here, is completely disappeared. Okay, there is no clear differentiation of the sacrum and the ilium can be made here, right? So we can actually understand that the insertion sites of all the tendons and ligaments of the joint capsules, okay, all of them are actually, see, this is the area where the joints has to be, the tendons, ligaments, and things has to be inserted. So all of them actually has increased density along this area. And at the same point of time, you see here there is a disappearance of the sacroiliac joints as well. Okay, there is completely, it is completely wiped away. So there is a complete loss of sacroiliac joint line. Well, you see here, uh, not exactly. You see here, sacroiliitis. Uh, why did you actually ask this question, Tebalina? So do you mean to say that you are looking at sacroiliitis and ankylosing spondylitis? Okay. Do you mean to say that ankylosing spondylitis and sacroiliitis as two different conditions? Well, no, not exactly. See, sacroiliitis means to say inflammation of the sacrum and the ilium joints there. It can be happening because of so many clinical conditions. Okay. It can be happening because of so many clinical conditions. And it can be also happening because of psoriatic arthritis, reactive arthritis, inflammatory bowel diseases, right? Yeah. So in such kind of a situation, actually, this is in such kind of a situation, yes, you call it as sacroiliitis. It is also associated with ankylosing spondylitis, but particularly in ankylosing spondylitis, what is seen? Sacroiliitis is seen. But generally, sacroiliitis is a different condition. Well, in ankylosing spondylitis, yes, sacroiliitis symptoms are seen, particularly starting along the sacrum and the ilium. So that's the reason we call it as that way. Right? Well, both of them are two different entities, but they are associated together. All right. Okay. Now, and you see here, what we can actually see here, there are the insertion sites. Actually, they actually show up. There is an overgrown growth formation, or there is an increased density along the tendinous and ligament insertion areas. And there is complete disappearance of the sacroiliac joint line. And also, there is another thing actually you see here, there is a complete fusion of the pubic symphysis. Pubic symphysis is completely fused together, where the sacrum and the ilium are also completely fused together. So, which actually suggests that this patient is suffering from ankylosing spondylitis. Well, and you see here, if the outer facets of the spine are joined together, where the syndesmosis, right, syndesmophytes are actually formed. So, such kind of one is actually forming up the spine to look like a bamboo. Okay, a bamboo root actually is continuous, right? There will be joints in between, but it is continuous, right? It is not one stack after another stack. It is not some kind of a lego formation, right? But from the outside, all of them are joined together. But when you cut the bamboo inside, you can actually see that there are different uh, stages, right? Stairs like things. So it is not only joined on the inside, but it is also joined on the outside. So such the condition, we actually call it as syndesmophyte formation, which actually gives us an appearance of a bamboo spine. This is the most important thing that you have to remember about ankylosing spondylitis. Is this point clear? Yes, right? You see here on the lateral side, you can technically appreciate it clearly looks like a bamboo tree. See, annular ringed fibrous formations. Okay, annular ring fibrous formations that are actually forming, and the joint is present down, so it is actually causing a completely bamboo spine appearance. Okay, these are fused and there will be restrictory movements, right? So I think, so that's it. We are done with the ankylosing spondylitis condition. Well, reactive arthritis and the other conditions, we are not technically, I'm going to add them in, infectious arthritis and tuberculosis. I'm going to add them in the practical slides. Okay, at least for here, until here you learned them. Okay, you have to understand the important points here in this one. Okay, every joint disease has got their own hallmark features, right? Okay, hypertrophic osteopathic formations, osteophyte formations, hypertrophic arthritis, which is primary arthritis or degenerative arthritis. Then Charcot's arthropathies, okay, which is happening particularly in diabetes. And then rheumatoid arthritis, which is actually happening in the distal interphalangeals and proximal interphalangeal joints. Gout, which is actually happening because of the formation of the ureate crystals. Ankylosing spondylitis, which is actually happening because of syndesmophyte formation. The whole chapter, if we are talking, is that yes, we are talking in single lines like this. Did you understand? It is not difficult. This chapter is fairly very easy. Very. The only thing is that everything, everywhere, you have to remember what are their hallmark features. And the most important question that will always be asked in any kind of a competitive exam is related down to the differences between these three clinical conditions. Okay, what is the difference between the osteoarthritis, rheumatoid arthritis, and gouty arthritis, or osteoarthritis, rheumatoid arthritis, and infectious arthritis or reactive arthritis? See, all the things they will be technically asking you, particularly which is related down to the arthritis. What are the main important differences? Most of the clinical questions will be actually coming down only on this one, because the diagnosis of osteoarthritis can be made out from knee, which is happening on the bigger joints. Rheumatoid arthritis is actually going to happen down in the proximal interphalangeal joints. Gout is actually going to happen down along the metatarsal, right? And then ankylosing spondylitis is going to happen particularly only along the sacroiliac joint. As simple as that. Did you understand? If you are going to tell about the overall summary, yes, we are going to tell them in single lines like this. That is the whole take home away point from for you here, right? Are there any doubts for this, all these things?